Dr. Alan Osford is clinical professor with the Department of Family Medicine at the University of Alberta and is actively involved in teaching medical students and residents. He's been practicing community family medicine since 1981 and currently has 1,300 patients in his panel. He has special interests in clinical informatics, diabetes, asthma, wilderness medicine, and acupuncture. He chaired and chairs currently many clinical IT committees and was Chief Medical Informatics Officer for the Health Region. His involvement is at a regional, provincial, national, and international levels in CIS, EMR, and HIE applications design, adaptation, integration, interoperability, change management, clinical decision support, patient portal consulting, and chronic disease management. He is currently a member of the Orion Health Clinical Advisory Team and co-chair of the Alberta Health Services Netcare Clinical Decision Support Committee. Thank you, Dr. Osford, for repeating your presentation that was originally delivered at our 2019 NMHIC HIE Users Conference.
Hello, everyone. My name is Alan Osford. I'm a family physician from Edmonton, Alberta, Canada, and I'm here today to tell you a little bit about our health information exchange known as Alberta Netcare. The objectives of the presentation today is we're going to talk a little bit about the value of healthcare provided by Alberta Netcare. To start with, we'll talk a little bit about the Canadian and the provincial Alberta context. We'll get into how we've put together things and how the information network works in Alberta. I'm then going to go into some use cases to talk to you about functionality. We're going to use screenshots for this, and we're going to sort of talk about it from a day in the life of type of perspective. We're then going to talk a little bit about benefits realization and what we've learned as well, so that we can sort of hopefully help others who are on this journey as well and share information back and forth so we can improve healthcare right across all of North America. So to start with, Alberta is roughly twice the size of New Mexico and roughly twice the population as well. You can see where we are on the map, much further north. I can tell you today we have a lot of snow flying, and in fact, the temperature last week was minus 40 degrees centigrade. Currently, we're around freezing. To talk a little bit about the Canadian context, basically, things in Alberta function through the Canadian Health Act. The Canada Health Act basically is something that's embedded, and it's why we have a presentation in terms of funded healthcare most of the time through the single payer. And you can see on there that basically the bottom line with this is that all funding for healthcare that is population provided comes from our federal government of Canada. And it's given to each of our provinces and territories, and they decide how it's spent, provided they meet the Canada Health Act requirements. And basically that means that typical information required, typical care provided needs to be at a basic level for all people within the country. From an Alberta perspective, just to give you a little idea of how we function as well, primary care is mainly fee for service, which means we get paid per encounter with patients. There is a smaller fee for performance component in terms of funding to improve certain things we do. For example, things like screening rates, pap test rates, mammogram rates, colon cancer screening rates. We also have primary care networks, and they are geographical groups where multiple clinics within a certain geographical area are provided additional funding to provide better population health. We'll talk a little bit about that later on. From a secondary and tertiary care perspective, basically we have a single health region for the entire province called Alberta Health Services, and most secondary and tertiary care is fully supported by Alberta Health Services. From a public health perspective, childhood immunizations, reportable diseases, things like home visits, those kinds of things are all provided from a public health perspective. From a continuing care point of view, including home care and including assisted living all the way up to nursing home care, Alberta Health provides funding for that as well and resources for that. Everyone on that list basically uses Netcare, which is the Orion Health Information Exchange that we've adopted starting back in 2004 with Edmonton and then 2006 across the province. Just to get the joy of terminology out of the way, alphabet soup is a common thing, and you see all these terms, and sometimes we get mixed up with different terminologies. In fact, in Canada, we don't use the word health information exchange. We call it an EHR, but I think in the United States, you call an EHR something slightly different. So I'm going to use the word health information exchange, and we'll talk a little bit about how we define that and what that is. But today's topic basically is about a health information exchange. So if we look at this from a provider-centric perspective and an electronic medical record perspective, a typical electronic medical record contains information that has a clinical summary, it has notes, medications, reports, care plans, diagnostic imaging information, and laboratory results. When we look at how people participate with this, it can be an individual, it can be a clinic, it can be departmental, or it can actually be at an organizational level, depending upon the size of the EMR and how it's deployed. A common term used is enterprise, and often people have some challenges around defining what we mean when we use the word enterprise. So I provided a little bit of a definition of the difference between what we would consider an enterprise electronic medical record system versus a local one. Basically, it's about scalability. Can it handle a lot of patients? Can it handle a lot of providers? Is there detailed role-based access? Does it have robust security and privacy to allow multiple different kinds of care providers access, but locked down to only the areas they need? And most importantly, the number of instances. We often hear about lots of local EMRs that will call themselves enterprise, but in fact, there's an instance of the EMR in Clinic A, and there's a separate instance of the EMR in Clinic B. So they're not actually sharing information. If a doctor posts a penicillin allergy at Clinic A, it doesn't show in Clinic B. And that's where a health information exchange really becomes a powerful tool. So if we look at this from the perspective of multiple providers, we have family physicians or general practitioners who will have their EMR. We may have a specialist, such as a diabetologist, who will have a different EMR. We may have care providers such as our chronic disease management nurses who may be doing diabetic care or COPD care, various kinds of things that way, who again are often on a different EMR. And then we have systems such as the emergency department in various hospitals who may be on yet another EMR. And the poor patient, of course, sits in the middle of this. And the challenge is that a lot of times information is not shared between those two areas. And that's basically where the health information exchange comes into play. What it does is it grabs pertinent pieces of information from each of these systems and aggregates it into a single location. So when we talk about EMRs, or in fact clinical information systems, and compare them to health information exchanges, it's important to realize that we're talking about two different kinds of tools that are both very functional and both very, very important. Sometimes you will hear that a robust, fully deployed clinical information system can replace a health information exchange. We find that's rarely true because it's very rare that a single place will have everybody on the same system, and that there are no one-off systems where you still need to pull information in. If we look at the functionality of a health information exchange, so we're now talking about Netcare, which is the Orion health information exchange that we use in Alberta, there's some key issues around it that make it unique. Number one is it's patient-centric. It is not provider or facility-centric. Information from multiple providers, from multiple facilities, from multiple organizations are all aggregated together at a patient-centric level. It's optimized for cross-platform aggregation, which means it can pull in pieces of information from various sources and aggregate them and trend them together so that you're looking at a single picture rather than looking at multiple pictures. And it includes a lot of tools for things like chronic disease management, for care plans, for referrals. There's a variety of tools that are in there that allow providers across multiple EMRs to work off of a single health information exchange. It's an easy item for initial clinical informatics adoption. There's not a lot of training to use it. It's rare that you can break it because most of the basic functions you're using is read-only, where you're aggregating information. So getting providers comfortable with using IT, it can be one of the easiest things they learn initially to get them to adopt things. It's obviously a shared information tool. And with the shared information tool, there are lots of functions that you can decide whether you will or will not use. In Alberta, for example, we decided not to have an active in-basket function within that tool. We do not want lab results being delivered to an in-basket in the Health Information Exchange because most of our providers are used to having that delivered in their EMRs. We did not want to have them work on two different in-baskets, for example. Other jurisdictions may decide that that's something they want to turn on. The other thing that's really, really important about a shared information tool is it is a great tool for doing analytics at a population health level that goes well beyond each individual EMR or those separate instances I was talking about to pull things together so you get a clearer picture. One of the other functionalities we find very, very important and very, very well used and adopted is the ability to do what's called a context launch. So you can be in your electronic medical record, you click the Netcare button, and immediately on that patient, you're in the Health Information Exchange and can see that information. You don't have to shell out to a separate system. You don't have to do an independent patient lookup. It's there immediately for your use. At the same time, there are some people who prefer to have it literally embedded within their EMR, and that capability is also there where basically you can have it function within the EMR rather than as a quick launch as a separate windowlet within the EMR. The other thing that's very important that we have found is there are times where sometimes EMRs fail. They may go down, there may be an upgrade that took longer than expected, there could be some major issues in terms of connectivity. And the Health Information Exchange often provides a contingency where, although your EMR is down, at least you have the basic information you need to care for patients while you're waiting for it to come back up within the Health Information Exchange. A little bit about Alberta Netcare statistics. You'll see that we've been around at a province level since 2006. Remember, our province is equivalent to your state. And you can see that we have had a lot of screens viewed since that time. We have many, many unique users on the system. We have a lot of physicians and residents that are using it as well. And one of the reasons why we get such good uptake and use is because we have data in there that everybody wants to see. And you can see from our provincial statistics, 96% of dispensed medications across the province are within the HIE, 92% of lab results, 92% of diagnostic imaging, reports, consults, discharge summaries, all those kinds of things. So the vast majority of clinical information that's needed for providers is in the Health Information Exchange. So who uses it? Well, this is a graph to show basically the different people that make use of it. And a lot of people assume doctors are the #1 user. In fact, they're not. They're the #3 user if you look at this. Administration uses it quite a bit. Nursing turns out to use it a lot, especially within hospital systems and again, when they're aggregating information in certain areas such as chronic disease management. So what do we have in our Health Information Exchange? We have a provider portal, which means that anywhere that you have access to the internet, you can launch this tool and view it without being on your EMR. You can do it on your mobile phone, you can do it on your tablet, you can do it from home when you're on call for a weekend, and you can get into information that you need to see. We also have the capability of running it within our EMR, which we talked about earlier. We have case management, which we'll show a little bit about coming up. We have our pharmaceutical information network, which is across the province and aggregates all dispensed medications so that you have them all in one location, regardless of who provided them. We have an imaging system, which includes a viewer for viewing all radiology and seeing images, which we can use both ourselves and we can also use to show patients. We have a cancer screening summary sheet. We have a lot of integration tools. There's something called CII and CPAR, which is what we use especially in family medicine to allow information from our family medicine electronic medical records to be pushed up to the Health Information Exchange. And we have the ability of rostering so we know which patient is attached to which primary care provider in terms of messaging, sending information, and making sure that they're included in the loop when there's secondary and tertiary care done. We have eReferral, and we'll show you a demonstration on that as well. We have the ability to create lists both in an automatic generated function from our ADT systems and also a provider generated list. We have the ability for secure messaging. We have resources and links, so common tools we want everybody to use across the province are available at the push of a button when you're on electronic medical health information exchanges. We'll talk a little bit about our data integrity button and our enhancement request buttons as well. So here's an example of an integration with a basic screen showing an Epic electronic medical record. You click the HIE button and what you get is the Health Information Exchange portal view right within the tool that you're using. Again, it's single sign-on, it's context launched, so you literally push the button when you're on John Cardinal, and you get John Cardinal in Netcare. One other thing that's an important concept is the concept of the medical home. And we know that both in Canada and the United States, this is a concept that has been gaining more and more popularity. We're striving to have patients be able to go to a single location and have things done for them and provided for them in a sort of unique way from a navigation point of view, and making sure that they only have to worry about one location when they're having coordinated care done. In Alberta, these are the goals for the medical home from the College of Family Physicians of Canada. And in fact, most of those are supported in a big way by Netcare, by our Health Information Exchange. So let's talk a little bit about a day in the life of a family physician. We're going to go through some use cases. The items that you see there in blue are ones where I'm going to actually show you screenshots and talk through it. The items in black at the bottom are not going to be specifically dealt with in this talk, but you can see by looking at them that the things we're going to talk about above will basically map to those kinds of things. So we're going to talk about a new patient when they present to a clinician and what they can do within the Health Information Exchange to ramp up quickly on that patient. We're going to talk about health maintenance, care coordination, eReferral, and transitions of care, which we've identified in our province as being a big ticket item to try and improve on. When we talk about transitions of care, we're talking about movement between different locations, such as from a home into a hospital, from an ED into a hospital, from a nursing home back to a home, those kinds of things. So when we're seeing a new patient, this is the kind of screen that you can pull up when you're looking at the patient. We've blanked out actual identifiers so that it's masked. So what we're looking at is real patient data, but we're not revealing who that patient is. And within this, there are a number of different areas, which I've put some color-coded boxes around so that we can talk about each of the areas. If we start with the event history, this is an example of a patient-generated list. So anytime a patient of mine is seen anywhere by Alberta Health Services in the province where it involves being registered with the ADT system, it populates this list. So at a quick glance, I can see where they've been. Have they been to an emergency department? Have they been to any outpatient facilities? Have they had special tests done? And it's this nice continuous view of all the places they've touched and where they've seen. We also have clinical data, and that's in our CDV tree, and that data is very, very valuable. That's the stuff that's aggregated across all the different sources, multiple different lab systems, multiple different imaging places, multiple different reports coming from different hospitals, different institutions, those kinds of items. And the beauty of this tree is it's quite configurable. So if you look at these different views, what you'll see is you can sort by category, which is things like chemistry, imaging, those kinds of things. You can sort by date. So if you want to look at it chronologically, you can sort by things that way. You can sort it by status, normal, abnormal, and others, because we know that transcribed reports we're not able to identify whether it's a normal or abnormal. You can sort it by author. So if a patient recently saw a certain specialist and you want to see all the work that specialist did, you can sort it that way. And you can sort it by the source. Where did they have their information generated? Was it done at a lab in Calgary? Or was it done in a lab in Edmonton? Was it done at a certain radiology location as well? This allows for a lot of flexibility and a lot of different use cases in terms of how you would use the system. And you can actually default the system so that when it starts, any one of these would be the starting point to your preference, and then you can change as you need to. When we're seeing a new patient, the other thing that's of huge value are flow sheets, where we're taking data and we're trending it. This is an example of a flow sheet where we're pulling information across all the different systems in Alberta and putting it into a single table where you can trend. One of the things that we've spent a lot of time on is making this more friendly to certain providers who require specifics. So for example, we have the ability to do what are called favorite searches. So right now what you're seeing in the green box is the standard flow sheet. If you select a favorite search, which you've created and decided that you wanted specific information on, when you click that button, this is an example of one where we're looking at cholesterol and blood sugars, you can immediately just narrow into those items to see and use. Also within any of these items, if there's trending required, we can do graphing with these things as well. So it's a very valuable tool both for teaching, and it's a very valuable tool for talking to patients about when we're trending. Another part of seeing a new patient that's a very important thing is, can we get as complete a medication list as possible? And that's where the medication profile comes into play. Basically, when you click the medication profile button, our pharmaceutical information network, which if you'll recall, we talked about well over 90% of dispensed meds are in the Netcare, you can actually look at these. And when you're looking at them, you can basically tell in a chronological order what meds they've been on, what the doses have been, how much they've been given, who the provider was, and even where they filled the prescription out. In fact, you can sort this in multiple ways as well. You can sort it into all the data. You can go down to 1 month. You can actually look at a detailed report, which shows a lot more information and puts all the meds in chronological order in terms of each med. So all the Ativan prescriptions would appear first, and you can trend those. All the duloxetine would show next when you're doing that report as well, sort of thing. The other thing that's important to try and put together is immunizations. We have multiple places in our province that provide immunizations. It may be a public health clinic, it may be a doctor's office, it may be in the hospital. This aggregates all of our immunizations into a single area to look at, so that you can see, if you look at the panel on the right, you can see all the different things that are being provided, and you can determine whether or not a person is due for additional immunizations. So that's a look at sort of that first view on a patient that you haven't met, where you're trying to pull a bunch of things together. Obviously, you can make use of all those functions for regular patients where they tell you they've been somewhere else and they've had care provided outside of your locale. Another thing that's very important is screening and cancer when it comes to health maintenance. And so we created a special folder that basically aggregates information as a cancer screening. And so on that CDV tree we talked about, if you click this cancer screening button, what you will see is the typical things that the patient is due for and when they last had them. So it will help you to decide whether or not they're now requiring other tests to be done. And again, the beauty of the health information exchange is that it provides all the information. So if I didn't do the last pap test, let's say they lived in Calgary a year ago or 2 years ago, and I live in Edmonton, I can still see all of the pap tests because this aggregates from across the province. Another area of real importance that we find is chronic disease management. And chronic disease management within the Netcare Health Information Exchange is a very valuable tool. Orion has many different ways of doing these kinds of things. Chronic disease management can be set up initially as a dashboard where you can then drill into patient lists, and then you can actually drill from the patient list into an individual patient. So for example, if we're looking at a diabetic, and we want to see how well are we doing for our general population. So this would be my practice. How many of my patients have blood sugars that have shown to be a target of less than 7 for their hemoglobin A1C, which is the green bar you'll see under the A1C. Those patients are doing well. How many patients are a little bit out of sort of the range we're looking for, and is there a reason for them? That's the yellow. How many people have an area where we're really concerned? And how many people haven't we done one on recently? And if you click on any one of those bars, what you'll immediately get is the list of all those patients. So I have 1,300 patients in my practice, roughly 150 diabetics. You'll basically see those diabetics, if I wanted to look at the really high A1Cs, who I need to target and work on. And in fact, it's often not me, it's our chronic disease management nurse, who does an amazing job of tracking all of these things for my practice with the use of Netcare. If you click on an individual patient, then you get this nice summary dashboard of all the things pertinent to that patient around their care management, which really assists whoever is doing the care management with having a great picture. They can phone the patient, deal with things, and make sure that they're doing proper care. Next, we're going to move into eReferral, which is an electronic referral system built into Netcare. And so when you're on a patient, if you click the Create Referral button, you can start to generate an electronic referral. Again, the beauty of this system, it is for referring anywhere within the province that is participating on eReferral, and it allows multiple people from multiple locations to see the status of the referral, to deal with what's going on with the referral, to complete the referral, all those kinds of items. So any referral, basically, when we worked on putting this together, and we were lucky to be involved with the development of this with Orion Health in Alberta, what we wanted was a single area to do referrals and tracking. We wanted to have something called the Health Services Catalogue available, and I'll talk a little bit about that. We wanted to know in real time what was going on in terms of access and looking at delays and being able to track things so that we could improve efficiency in the system. We wanted to support not just a basic referral that's a face-to-face, but also what's called a referral for advice. So we could do an e-referral for advice, which means that you don't have to wait for an appointment. A specialist can read the referral and provide you with advice. And in fact, just yesterday I did one of these, and it made a big difference in short-circuiting what we needed to do on a patient rather than waiting 2 months for the appointment with the specialist. We have standardization around forms for both a generic referral and there are custom referrals, and we'll show you a little bit about that. We have the ability to triage, and there's some automation behind it and scoring capabilities. We want to make sure that people aren't having to provide repetitive information when they're doing referrals. Remember, most of the important data, such as lab and imaging, is already in Netcare, so why do you need to photocopy it or send it electronically when it's already there? We just point to it within the system. And we want to support both providers and patients with electronic communication so that at any given time you can look at the status of referral, see what's going on. And finally, and very importantly, we wanted analytics that helped us to optimize referrals as well. So we talk about the Health Services Catalog. Basically, if I'm doing a referral for somebody with osteoarthritis of the hip, the beauty of this catalog is it allows me to slice and dice in many different ways in deciding how to go about referring and who to refer to. I can simply refer to a specialty, which is a referral to service, or I can actually refer to a specific provider. When I'm referring to a provider, I can actually see whether that provider actually does what I'm referring for. So we have some orthopedic surgeons who only do back surgery. They don't do hip surgery. Well, if I've clicked the reason for referral as being osteoarthritis, the only providers I can search for will be ones who do that. I can also look at which facility they work out of. Some patients have specific requirements that way or interests that way in where they would have it done. And I can also narrow it down to which zone. So the Edmonton zone is where I would normally narrow it down to because patients usually don't want to travel 3 hours to the south to Calgary and see a very, very poor hockey team play compared to the Edmonton Oilers. The other thing that's really important is making sure that you're doing an appropriate referral. And often we're told by specialists they get sent things that shouldn't be sent to them. They're more urgent in nature. So as you're doing the referral, you can actually see those criteria to help prevent that from happening. Wait times are a very important thing. One of the downsides of the system we have in Canada is waits for surgery that are non-urgent can sometimes be quite long, and you can tell that by looking at these numbers here. For urgent requirements, our response times are very, very quick, and we don't have any problems in that area. But often if you need a hip replacement, you can wait quite a while before it gets done. If you look at this, for example, in the Edmonton Musculoskeletal Center, it can be up to 300 days before a procedure actually gets completed. That's from the time I initiate the referral to being seen, being triaged, being seen by the orthopedic surgeon, being put on the wait list, to having a bed available in the hospital, and completing the procedure. If you look just above the Edmonton one, you'll see that in Westlock, it's 84 days. And in fact, Westlock is only a 40-minute drive from Edmonton. So looking at this can sometimes help us to optimize where we're going to send patients and try and do a better job. Also, tracking it makes a big difference in terms of telling how do we improve things, where are the bottlenecks, and what are we doing that way. One of the other things that's important is we want to make sure that the required information is available to the referrer so that we know that they've got the information they need. And so this is those specific areas where they tell us exactly what we want, and we make sure that we've done all of those things, and they're either attached or we can say they're all available in Netcare. Another area is the automated triage. So this is an example of referring somebody for a hip replacement where we score them based on what's going on with their symptoms and their medications. And on the basis of that, an acuity is shown, and you'll see that the score on this one is 75. Depending upon the situation, if things change, we can always go in after doing the referral and change these and change the triage level. And again, recently I had a patient who we had to change from a moderate to a high, which resulted in them getting seen much sooner. We also have dashboards in eReferral that allow people who are doing triaging to see what's going on and track what's happening. We also have a way of viewing how well are we actually doing when we set targets and we look at elapsed times in the context of actual referrals that are on the fly sort of thing. So again, you'll see access target, elapsed time, and if they're over time, what to do about it sort of thing. We tend to timestamp all the different steps in a referral as well. And again, it helps us to identify the bottlenecks. So that's a referral. One other thing we said we were going to talk about was transitions of care. And so one of the tools we have there are these ADT generated lists. So what you'll see where the arrow is pointing is you can see inpatients, for example. So basically using this tool, I can see any patient of mine who is being admitted to the hospital, not just the hospital I work out of, but any of the hospitals across the province. And in fact, I can track what's going on with them and see what's happening with them by generating this list, which is automated. I just have to push the button to see it. The other thing you can do with this is if you're making rounds, on a weekend, I can generate the list for all of my partners in our clinic who all have patients in the hospital and use it while I'm making rounds on them. At a higher level, we sometimes have a urologist, for example, that may be on citywide call for emergencies. They can actually track all inpatients across all hospitals and be able to quickly find a patient when their call is made to make decisions on it in case they're not in the hospital at the time. We also have provider generated lists. So what that is basically is it's a list I can add patients to. And a common example of that for me, I have some very complex patients as a family physician. They may be a transplant patient, they may be a serious cancer patient. By putting them on my follow-up list, I remember on a daily basis just to click in there, have a look and see who have they seen, what system is working on them, has anything changed, because I may not get all of that information sent to me in my EMR. So I can track if they've been to the cancer clinic and the treatments they're getting. I can track that they've recently been in the emergency department, those kinds of things. Also, you'll see a resident 3 there for our learners. They track the lists of the sub-panels that they're caring for as well, and it's a very important thing for them to be using in terms of knowing what's going on with patients and learning. Then we have medications. We talked a little bit about the medication list you can generate. We also have the ability to do medication reconciliation. And when you click on that, you can generate electronically or a paper form that you can give to a patient as they're leaving, say, a hospital or an ED, that reconciles their meds. It pulls all the meds on their dispensed list from the Pharmaceutical Information Network, and it allows you to check off, stay on this one, no, stop this one, change this one, and you can view that and see what's going on with it. The patients get that, and often patients prefer to have that on paper because some of them aren't sophisticated enough to have it electronically as well. We're also going to talk about, I mentioned the data integrity button. So this is an example of a male patient that had a pregnancy test done. And they don't have any endocrine problems. And so the question is, what's going on here? What happened? Why is a man having a pregnancy test done? And it turns out there was a data integrity issue. And in fact, this was not his pregnancy test. This was somebody else's. So rather than have to go through a lot of detail and trying to figure out what's going on with that, I simply click that data integrity button. It pulls in the pertinent information, who I am, what patient I'm looking at, and all the rest of it. And I just quickly type a message in there saying, not sure this preg test is for this male. And then that is sent to our data integrity team to clean up that data problem. We also have the ability to do enhancement requests and those kinds of things as well in the system. So let's talk a little bit about benefits realization. Obviously, the things we talked about earlier, the fact that we have the majority of important data in the system really makes a big difference in terms of being able to aggregate data. We talked about the functionality of eReferral. We talked about chronic disease management and the ADT feed lists. All of those we found huge benefits to. They make a big difference in the care that we provide. They make a big difference sometimes in some of the wait times that we run into as well. Another area that we talked about was medication management. We can see dispensed medications, we can reconcile medications, we can look at allergies and intolerances that are aggregated in a proper fashion. We can look at monitoring of medications such as opioids, benzodiazepines. The Beers criteria has to do with medications that are not recommended in seniors and elderly people. And we can improve transitions of care. Well, so what lessons have we learned in the last 14 years? Well, at a very high level, we know that executive support is absolutely critical to success. And in Alberta, that meant getting together all the key organizations to all agree that this is important and to support it. So that's the Medical Association, that's the Medical Regulatory Body, that's the Nursing Association and Regulatory Body, that is our College of Physicians and Surgeons, that's our family practice groups as well as our PCNs, that's Alberta Health Services. All of those people need to sit at an executive table and support this project for it to work well. We also know you need a sound clinical governance structure to make decisions. And having a clinical governance team meet on a regular basis, which I know you do in New Mexico, really makes a difference in success. We also know that vendors know a lot more than we think they do. And this is a learned lesson over time. Often we will have our providers, when we're building these things, say, I want it this way, this way, this way, this way. But our vendor will say, Orion will say, well, are you sure you want that? Because our experience with 15 other places is that didn't work well for them. And so listening to your vendor when you're doing these things is a very important thing. Other lessons learned. The idea that a single system-wide EMR CIS will solve all problems, it's a holy grail. It's great to try and achieve, but we know it's going to be a challenge. There's going to be different CISs in the systems. There's going to be different EMRs in the systems. So you need something to pull it together. We also found from an engagement point of view, it makes a big difference. One of our mantras was the quarterly pearl, which meant every 3 months we would add a new piece of functionality to the system. And we tried to add the piece of functionality that our providers told us they most wanted, rather than making our best guess with it. We have that data integrity ability I told you about, and we basically have found that an HIE dramatically facilitates team-based care, because often team-based care, when they're not all on the same site, is fractionated. Well, when you have a common tool to communicate in and to view off of, it makes a big difference. We know it's an excellent global communication tool. We also know that it's great in downtimes for other systems to be able to allow you to continue functioning, seeing patients. What did we learn about privacy and security? Well, it's this sweet spot sort of phenomena here. If you have too much privacy and too much security, no one's going to use the system if they have to use a 52 password, if there's 52 characters in their password. We also know if there's only a few characters in their password, it's not going to be trusted or provided. So you have to figure out where that sweet spot is in terms of making sure that it's balanced. We know as well that privacy impact assessment tools and information sharing agreements are very important, and people need to understand how they work and make sure that they participate actively in them, including the organizations that represents the different providers. We need to understand the idea of risk versus benefit. There's no such thing as a perfect system in either direction. There are some things we do that we know will introduce some risk, and there's some things we know that will introduce great benefits. Again, there's a sweet spot in that area of figuring out what works best, and that's where clinical governance really becomes important in terms of helping to guide those decisions. When it came to actually looking at patients who were concerned about their privacy, we were quite surprised. We started out basically with an opt-in system, and we found very shortly after going live, within a year, that the vast majority of patients wanted to opt in, and we switched to an opt-out because there were so few patients that didn't want to be in. We didn't want to be spending all our time working on patients opting them in. So we have an opt-out system. In terms of experience, what have we learned? We've learned that what people think they want initially may be different from what they want once they've got used to the system. Often people say, I want a simple screen, I want really big icons. When they first look at a system and they're learning it, 6 months down the road, they will tell us, I want really tiny icons and I want as much functionality on the single screen as I can get. So understanding that and making sure that people are involved at both ends of the spectrum in design is very, very important. We know that integration is a very important thing. We know that workflow can sometimes be quite a challenge. Often we have providers who are quite proud of the fact that they have what they call unique workflow. My workflow is very different than anyone else. You need to make sure the system supports it. What we find when we talk to them is often their workflow is not that unique, even though they think it is. So basically we have 3 or 4 major workflows we look at in different systems, and then we try and see whether they fit within one of those. We also know that process improvement readiness, have they been through understanding what process improvement is? Do they understand how to modify their day-to-day activities when they have these new tools is very important sort of thing. And if they haven't gone through that, making sure we support them. And going through that transition period can be painful, and understanding how to support them makes a big difference. We know for sure that clinicians, once they're used to the system, would not go back to not having it. They rely heavily on the HIE. You saw that with our statistics that we showed at the front end of the presentation. We also know that remote access improves patient and physician health in terms of care. Not having to drive into a system to pull up information or look up a chart, being able to take call and be able to remotely pull it up on your tablet and make decisions and advice without, again, driving into the hospital can make quite a difference in terms of care. So how do we change the culture? You can't just talk about it from a technical point of view. You have to talk in terms of real clinical stories. We know that peer-to-peer training is very important. And we talk about champions and super users. A champion is somebody who really is the raw person. They're the cheerleader for the system. And if you have a champion in each sort of major location where you have a health information exchange deployed, they can really help people to learn how to use it properly. A super user is a different animal. Super user knows how to leverage every sort of drop of value that's in that system out of it and how to configure things. They're important as well. Often super users are not the greatest champions because they have trouble understanding why people struggle with using the system. So we have both of those roles. And if you're really lucky, you could find people who meet both of those roles as a single individual. We have demonstration clinics where we show people a family practice clinic that leverages the HIE in a big way to a clinic who's not so up to speed on how to use that. And by spending a half day watching a day in the life of them using it, it really makes a difference in them understanding. We still have some people, even when we do that, that are challenged, and that's where we have a mentorship program. We may have a peer-to-peer connection with somebody to spend a few days with them to really help them understand the value. An important concept also is optimization. How do we make sure people are getting the full value out of the system? Circling back to a retraining 3 months, 6 months down the road and showing them a lot of the tools again and showing them some of the value added things can make a big difference in uptake of the system and leveraging the system. We know that you have to have protected time, and we know that we have to protect time not just from a specific time point of view, but from a capacity point of view as well. We know that change management systems is very important. We know that standards are important, but holding up a project on the basis of not having the perfect standard with every single system meeting it should not hold you up from deploying things that are of value. We also know that optimization for things such as filters that I showed you make a big difference as well in terms of making things more simple to use and quick to use. So I'm going to let you read this new professionalism as well. One of the commonest questions we get asked is, will this become a standard of care? And we have found that for certain areas, it is now becoming a standard of care. One of the most important ones are opioids. If you're going to prescribe an opioid in this province, you have to look up their dispensed meds in Netcare to be meeting the requirements now. We also know that audit logs can be used to assess performance, and that needs to be decided at a level of making sure everybody understands whether it will or will not happen. We also know that automated performance indicators can be used by administrators to assess programs. And again, there needs to be discussion around how that is done. And we need to make sure everybody understands what the information sharing agreement requirements are. So that's the end of my presentation. People may have questions and they can get a hold of us and discuss it, but I'm going to leave it at that. And thank you very much for allowing me to present.